EKGs can feel overwhelming, but in reality, the board exams only test a handful of EKG patterns. In this video, I'm going to show you a nice, simple algorithm that you can use to tackle most EKG patterns that you see in front of you and know exactly what the next step will be. Let's get right into it. Now, when I have an EKG problem in front of me, the first thing I'm trying to determine is what category does this patient fall into? In other words, are they pulseless? Are they having ST elevations? Are they tachycardic with instability? Are they tachycardic and stable? Or are they bradycardic? Or do they have pauses? So first, are they pulseless? If I'm dealing with a pulseless patient, I know I'm either dealing with one of four diseases. For example, if I'm dealing with VTach or VFib, I know that those are the only two shockable rhythms, and I'm going to go ahead and defibrillate. The other two pulseless rhythms that exist are either PEA or asystole, and those guys don't get any shockable intervention. Instead, you just continue CPR and continue to give epinephrine. Second, I'm asking myself, am I seeing any ST elevations? If I see ST elevations in the EKG and they're in two or more contiguous leads, then I know that I'm dealing with a potential STEMI, in which case the most important thing that I'm going to do is activate the cath lab and then give that patient aspirin, ticagrelor, and unfractionated heparin. Meanwhile, if I see that those ST elevations are kind of diffusely throughout the EKG, and the patient also has like pleuritic chest pain instead, and their chest pain seems to be more positional, like worsened with leaning forward, then I'm thinking, hey, this might be pericarditis, in which case the patient's getting NSAIDs and colchicine. If I have a tachycardic patient and they're unstable, meaning that they have something like hypotension or they look very obtunded, then I ask myself, am I dealing with a tachyarrhythmia? In other words, an EKG where I don't see a P wave and it's pretty fast? I don't care which of the tachyarrhythmias it is, I'm going to go ahead and synchronize cardiovert that patient. Meanwhile, if I'm dealing instead with a sinus tachycardia, like I can actually see P waves and it's just fast, then I just got to treat the underlying cause like infection, fever, etc. If I'm dealing with a tachycardic patient that's instead stable, I know that I'm only dealing with a handful of possibilities. If they have wide QRS complexes, that is VTAC till proven otherwise, and that person is getting amiodarone. All of these stable tachycardic patients get medical treatment. If I have a patient who is stable but tachycardic, and I see a narrow irregular rhythm, that is atrial fibrillation until proven otherwise. And again, these guys get medical management. So he'll or she'll get beta blockers, calcium channel blockers, and then we'll determine the anticoagulation possibilities using Chad's VASC. If it's a heart rate that is in the 150s or something around that, that is atrial flutter most likely. And that again gets managed very similarly to atrial fibrillation with medical management. If I see a heart rate greater than 150, to me that is SVT most likely until proven otherwise. And those guys, we're going to get some sort of vagal maneuver first, which usually doesn't work. And then we're going to go for adenosine if those vagal maneuvers fail. If the heart rate is less than 150, most likely that's sinus tachycardia, and those P waves are just getting buried in the T waves because it's so fast. And again, you're going to look for that underlying cause of like fever or whatnot and treat that instead. Meanwhile, if I have a patient who is now bradycardic on EKG, or I'm seeing pauses on the EKG, then I'm asking myself, are they symptomatic or are they asymptomatic? If they're symptomatic, the treatment is always the same. You're going to start with atropine. Atropine is going to hopefully reignite that AV node and allow for that heart rate to come back to normal. But if the atropine doesn't work, then these guys get transcutaneous pacing. Meanwhile, if I have an asymptomatic patient, then I can ask myself, all right, which of the bradycardias or possibilities of bradycardias could I be dealing with? Like, is it, for example, a complete heart block where I'm going to see PR dissociation? In that case, I know that these patients will eventually need a permanent pacemaker as their definitive management. If, on the other hand, I'm seeing that there are pauses after the P, that's almost always going to be a second-degree heart block. And so if I see that the PR interval keeps growing and then you get that drop of QRS, that's probably Mobitz 1, and in which case I'm going to treat the underlying cause, like coronary artery disease or some sort of medication that they're on. Meanwhile, if I see that there's a stable PR interval, the PR interval is always the same, and every now and then you're going to drop a QRS, then that is most likely Mobitz 2, and that will eventually require a permanent pacemaker, just like a complete heart block, because Mobitz 2 has a high risk of going into a complete heart block down the line. So let's now take that method that we just learned and employ it for a few of these EKG cases. So in every one of these cases, I'm going to present you with a clinical vignette. And remember, that's very important because often we're asking ourselves, is this patient stable or unstable, pulseless or having a pulse? And that can change your management. So in this first EKG, we see that we have a 42-year-old male coming in with palpitations and lightheadedness, and the blood pressure is 130 over 72. So I already know I'm dealing with a stable patient, but in general, I'm asking myself, am I dealing with any of these categories? Are they pulseless? Nope, they're not. Do they have ST elevations? I'm taking a look at each one of the leads and seeing, do I see any signs of ST elevations above the baseline? No, I don't. Am I dealing with an unstable tachycardia? Well, the blood pressure is normal, so no, it's not unstable. Am I dealing with a stable tachycardia? And I definitely see a tachycardic EKG here. You can use whatever method you would like to measure the heart rate, but I personally like to see that I have a QRS lined up close to this line over here, and I like to do the method of every box that we go, it's 300, 150, 100, 75, and it keeps going on. But here I have 300, 150, and I can see that this heart rate is a little bit faster than 150. So I'm definitely dealing with some sort of stable tachycardia. The next step is going to be to determine which of these stable tachys am I dealing with. Do I have a wide QRS in this situation, wider than 120 milliseconds? Nope. So that's not a VTach. Am I dealing with a narrow but irregular rhythm? This rhythm actually looks fairly regular to me. So instead, I would say that this looks like a heart rate of greater than 150 in a narrow, regular rhythm, which is classically going to be your SVT or supraventricular tachycardia. So the treatment for SVT is always going to be in a stable patient, vagal maneuver first, and if that doesn't work, you're going to go ahead and provide adenosine as an IV medication. So let's try this next vignette over here. You got a 62-year-old male who's complaining of chest pain and shortness of breath, and they have a blood pressure of 118 over 80. So again, I'm asking myself, are they pulseless, ST elevations, tachycardic, or bradycardic? So in this situation, patient clearly has a pulse. They're able to tell you they're having chest pain and shortness of breath. They have to be alive to do that. Now I'm going to see, do I have any ST elevations? And when I scan through this EKG and I look at each one of the individual leads, I definitely see ST elevations in lead 1 and lead AVL. And so I'm worried right now that I'm dealing with a possible STEMI because lead 1 and AVL are technically lateral leads. These are contiguous leads, so this is a STEMI until proven otherwise. So now I'm asking myself, am I dealing with, again, contiguous leads or is it diffuse? And I know that I'm dealing with contiguous leads here. So the next step in this patient who I'm suspecting is having a STEMI is going to be to activate the cath lab. While I'm waiting for the cath lab to prepare, I'm going to provide the patient with aspirin, ticagrelor, and unfractionated heparin. Let's try this one next. Here you have a 72-year-old male who is brought in by ambulance, and he became pulseless en route. So again, I'm asking myself the same questions. Am I dealing with a pulseless patient, ST elevations, tachy, or Brady? Here, I already know that the patient is pulseless, and that's pretty easy because there aren't many options for patients who are pulseless. You have either VTach, VFib, PEA, or asystole. And in this EKG, where I see that I'm seeing QRSs that are kind of chaotic looking, almost like a 5-year-old went across my kitchen wall and started scribbling across of it, I know that I'm probably dealing with a ventricular fibrillation. VFib, along with pulses VTach, are the only two rhythms that are shockable, so this guy or gal is going to get defibrillation. And of course, continued CPR. All right, in this next one here, we have a 64-year-old female who's presenting with palpitations and shortness of breath and has a blood pressure of 130 over 90. So again, I'm asking myself one of those categories, is it pulselessness? Is it ST elevations? Is the patient tachycardic? Or are they bradycardic? So certainly they're alive, so they're not pulseless. I don't see any ST elevations as I scan through this EKG. The patient does appear to be tachycardic, and again, use whatever heart rate method that you want to use, but they certainly seem to have a heart rate that's faster than 100. And I know that I'm dealing with a stable tachycardia because the blood pressure is normal. Next, I know there's only a handful of stable tachycardias, so I'm asking myself, is this a wide complex tachycardia? Is this a narrow complex tachycardia? So it's not wide, it's not VTach. It is a narrow complex tachycardia, and the rhythm definitely looks irregular. Those QRSs don't seem to be uniformly spaced apart. Well, we know that in any sort of narrow, irregular tachycardia, that is AFib till proven otherwise. So the next thing we're asking ourselves is, what are we doing for someone who is a stable AFib? Stable patients are usually medicated. So for that reason, we're going to go ahead and give the patient calcium channel blocker or a beta blocker to help lower that heart rate, and then we're going to consider anticoagulation for this patient using Chad's VASC. All right, let's try this next one. We have a 64-year-old female who presents to the office for routine evaluation, so sounds like they're asymptomatic, and their blood pressure is 140/92. So again, I'm asking myself, do they fall into any of these categories? And I'm looking at the EKG. I certainly don't see any ST elevations. I know this patient's not pulseless. I don't see a tachycardia, but I do see some pauses. So now I'm asking myself, the next question, if this patient has Brady or pauses, are they symptomatic or asymptomatic? If they're symptomatic, I know they would immediately get atropine. But this patient, remember, just came in for routine evaluation. So then I'm asking myself, all right, which of those heart blocks could I be potentially dealing with? Do I see any complete PR disassociation? Jesus, right? Where I see that the P waves are moving at their own rate and the QRSs are moving at their own rate? No, I don't really see that. Do I see instead some pauses after the P? And I certainly do. I see a few areas here where after a P wave, there's just a straight up pause. And it does look like that PR interval seems to get longer, longer, longer before I finally drop one of the QRSs. So inherently, I know that I'm dealing with a type 1 second degree heart block. And I know that those guys just get the treatment of the underlying cause. That could be coronary artery disease, or it could be evaluation of some of the medications that they're on. All right, let's check out this next one. In this patient, we have a 64-year-old female who's presenting with palpitations and shortness of breath, but their blood pressure, 70/40. It looks like I'm dealing with a hypotensive patient. So again, I'm scanning through. Is this a pulseless patient? No. Do I see ST elevations? No. Am I dealing with an unstable tachycardic patient? It does look like I am, because when I look at this EKG, I certainly see a heart rate that is faster than 100. Remember that when you're dealing with an unstable tachycardia, there's only one of two possibilities that you actually care about. Are you dealing with a tachyarrhythmia, where you're dealing with a pretty fast rate and no foreseeable P waves? Or are you dealing with a sinus tachycardia, where you actually can see the P waves? Well, here, I definitely don't see anything that looks like P waves. So to me, this is an unstable tachyarrhythmia, and there's only one option for those guys, and that is synchronized cardioversion, regardless of what type of tachyarrhythmia you're dealing with. Now, of course, in this situation where I'm seeing an irregular rhythm with the absence of P waves, I know I'm probably dealing with atrial fibrillation. But again, I just want to show you that when it comes to the management, if you use this algorithm, you really don't have to worry about which of those you're dealing with. An unstable tachyarrhythmia, whichever of it is, gets synchronized cardioversion. All right, let's try another one. So in this one, you have a 71-year-old female who's coming in with shortness of breath and weakness, but their blood pressure is 56/38. So again, ask yourself, are you dealing with one of these categories? I know this patient has a pulse because they can talk, but it doesn't seem like I'm dealing with any ST elevations on this EKG either. And then I'm asking myself, am I dealing with a tachycardia, especially in an unstable patient? And I already know they're unstable. That blood pressure gives that away. But I'm also taking a look at this EKG and seeing that they have a pretty fast heart rate as well. It looks like anywhere between 300 and 200. Remember, if you find yourself with an unstable tachycardia, you're asking yourself, am I dealing with a tachyarrhythmia where I don't see any P waves? Or do I have a sinus tachycardia where I can actually see some P waves? I definitely don't see anything that looks like P waves on this EKG, so I'm going to presume I'm dealing with an unstable tachyarrhythmia, which, regardless of what tachyarrhythmia you're dealing with, they're all going to get synchronized cardioversion. Now, I know that this patient specifically is dealing with an unstable VTach, because when you take a look at those QRSs, they look like those classic pine tree patterns that I had talked to you about. So what if you're dealing with this patient instead, who has kind of the same EKG, right? But is pulseless as they're being brought into the hospital. Well, when you're dealing with someone who is pulseless, we know that we only have really four possibilities. We're either dealing with a VTAC, VFib, PEA, or asystole. And again, when we looked at this EKG, we saw those classic pine trees. So this is a pulseless VTAC, and we know that that is one of the two rhythms that receive defibrillation as the treatment. So this person is going to get defibrillated, and then you're going to continue good CPR and epinephrine. All right, let's do this one next. You have a 64-year-old female again, presenting with palpitations and shortness of breath, and normal blood pressure of 130/90. So again, I'm asking myself, do they fall into any of these categories? Certainly not pulseless. I don't see any ST elevations. They are not unstable. And looking between Tachy and Brady, I definitely say they're closer to the Brady end. If you use that heart rate method, they are like well below 30. So when I'm dealing with a bradycardic patient, the next thing I need to ask myself, is this patient symptomatic or asymptomatic? This patient has palpitations and shortness of breath, so certainly in the symptomatic category. And all of these symptomatic bradycardias get the same exact treatment. They're going to get atropine, and if that atropine doesn't work, then they are going to go for transcutaneous pacing next. So the next time you have an EKG in front of you, just follow this nice simple algorithm, and I assure you you'll know exactly what to do next. I'm going to create a few more videos starting with GERD as our next video coming up, so be on the lookout for that, and I'll see you there.